of Futureproofing Public Health webinars. My name is Renee English. I'm the head of the Division of Health Systems and Public Health, and I'm very pleased to be hosting this particular seminar and also being able to introduce our presenters. The topic of today's webinar series is called Designing Health Systems for the Future, Exploring Multiple Perspectives. And really, the purpose of this particular series is to start talking about the future, talk about public health, and of course, health systems related matters pertain to the issues of public health, and to start discussions and explore multiple perspectives around a range of issues around what the future of public health is, what it is we can learn from other disciplines, and how we as public health practitioners can collaborate across disciplines and both learn from and inform what happens within those disciplines. So what we are hoping to do with this particular series is to ignite a conversation, get multiple perspectives, and really just start talking. What we hope to do in the future is to be able to get some of the practitioners who work in the services about whom we will be speaking to respond from their perspective, to speak about some of the challenges or even to challenge the perspectives and the ideas that are presented here. We have a future focus today, and the idea is to explore the concept of rethinking and designing health systems for the future. The order of presenters would be Rafeeq Bosch, followed by Prof. Alex van den Heever and Robin Dyers, and they'll be speaking from their various perspectives. So please join us. We'll try and keep it short and focused so that there's time for discussion, and I would ask each speaker to introduce themselves as we start the presentation. So without further ado, I'd like to hand over to Rafeeq Bosch. Thank you very much.
Thank you, Renee. I just want to quickly, if I can share my screen, and then I will do the quick 30-second introduction. Please, can you confirm that you're seeing a rather distressed-looking gentleman with the word future-proofing? She's right.
I am, and then I'm also seeing another document. Yeah, there we go. Thank you.
Oh, sorry. That's moving the team session around. Okay. Well, yes. Thank you, Renee. Everyone, morning or afternoon. This is Rafeeq Bosch speaking. I am a strategic foresight consultant and a futurist. I am currently engaged in my PhD in future studies at Stellenbosch University. My topic of research, or my research area, is about using futures techniques to help emerging economy countries participate better and participate more in the fourth industrial revolution. My lens on the conversation today really comes out of the 10 years or so that I spent in the private healthcare industry in South Africa and the rest of Africa. I did some stints at Old Mutual Healthcare and also at Liberty Health, and in that capacity we expanded the private health insurance offerings to, I think it's something like 17 countries around Africa. Renee, I'm going to dive in if that's okay. I know we're trying to keep to a schedule here. I've got about 10 or 15 minutes worth of stuff I want to talk about in this slot, so I'm going to go ahead if that's okay. I do want to start out and say that I'm beyond thrilled to be able to join the panel here today. Alex, I've followed Alex a long time from my time in the medical aid industry and some of his ideas on health economics, and I'm also excited to have collaborated with Robin in coming up to this webinar. So thank you for including me in this esteemed panel. I feel very poorly qualified. So my understanding of my role in today's webinar is to represent the futurist point of view on the question about the future of public health systems. As an opening thought, I wanted to share this picture, which I will caption as the distressed futurist. Now, at the risk of sounding pedantic, I will say that this stress is born out of the notion, this word future-proofing, which comes up in the title of the webinar series. Yes, I think futurists are probably overly sensitive about words like this, but I think for the purpose of today's discussion, it can actually be instructive to spend a couple of minutes talking about why a word like future-proofing stresses us out, or stresses me out, certainly. And I hope that in that process, I can actually expose some of the core concepts that sort of underpins the futurist mindset, which we want to understand a bit better today. So the first core concept is this notion that the future is actually an inherently plural concept. So I'd like everyone to pay attention as I talk to little nuances when I talk about futures in the plural a lot more than I do about the future in a singular sense. And it's this plurality that is also linked to the idea of mutability or changeability of the quote unquote future. So we think of the future not as fixed, although we can have ideas, we can have some sense of what is likely to unfold, but certainly futurists don't view the future or view our future as, that we are prisoners of some pre-written inevitability. So there's a strong sense and outlook about the idea that we have agency regarding our future. And so that's also why you'll find that futurists tend to bristle whenever we're asked for anything that feels like it's, asking for a prediction about something that is going to happen in the future. So yes, indeed, we do talk a lot about anticipation, and you hear us use words like forecasting and projecting in our discourse. But this notion of agency in what the future turns out to be draws something that feels like a conceptual, like a red line at the idea of predicting. Because I think predicting goes against this worldview that from an individual perspective, reality is just a constant choosing between a range of alternative possible futures. We're always at choice and choosing. And that when you aggregate that up to a societal level, the future is just this constantly emerging reality that arises from the aggregation of all that constant individual choosing. So I hope that starts to shed some light on why future-proofing feels a little problematic. It's really because of these connotations about inevitability and knowability and the fixed nature of the future. I think futurists tend to distance themselves from those ideas. It does go a little bit deeper as well, especially when you take this proofing part of the word into consideration, because that proofing holds aspects or that proofing aspect holds connotations about, maybe think of it as a negative future. Proofing, when you proof, you protect yourself and safeguard against something. And so, when you think about the idea of protecting ourselves against the future, now certainly there are dystopian images of the future that, that are valid and important even. But I feel as a futurist that I have also an obligation to call out, that there's a danger if we confine ourselves too much just to thinking about scary futures that we are trying to avoid. And this is because there's another valid kind of image about the future. You'll hear sometimes the word the utopian future. If we focus too much on the dystopian images, then we run the risk, I think, of locking ourselves out from that those more aspirational energies that may, in a particular situation, be more necessary to achieve whatever alternate future it is that more of us would prefer and would want to pursue. And so, I kind of make this distinction between, we don't always want to end up running away from something we fear. Sometimes it's more productive to run towards something that we desire. You may achieve the same outcome, but the sort of energy you come with into that endeavor will change. So I'm sorry for taking a lot of time to lay all that out, but I hope it does set up at least some kind of a basis for the webinar audience today to discern between different and not always necessarily compete. You're going to hear a couple of different perspectives today on this, and these aren't always competing perspectives, but certainly we're all talking about how to deal with a problem like the future of public health systems. And so how would a futurist address and approach that specific question? Well, I'm mindful now that I'm at the risk of painting futurists as a sort of a monolithic, unibrained collective. So let me just suggest that many futurists, including this futurist, would move from a point of conceptualizing healthcare as a system. And here I'm using system as a technical term, meaning that its properties and behaviors arise from the properties and the interactions between the components that come together to create the system. Such a futurist would then want to model the system to try to uncover drivers underpinning the system's performance and the behavior. And the diagram on the screen there is one of several models for sort of conceptualizing system designs and outputs and whatever. And so the range of alternative configurations and alternative component states and how those things are put together define a set of alternate future states in this or for this complex adaptive system, which we call public health or the healthcare system or whatever words you want to use. So the other term you will hear from futurists also is about scenarios, and these scenarios are really descriptions of these alternative future states or futures. And they can be explored for preferability by an individual, lone researcher, whatever, or a group of people. The group approach is typically preferred because usually the moves required to sort of come off the by default path or the probable future of any kind of societal scale system usually involves concerted action from a number of distinct and then often warring parties within that system. And there's this fascinating notion in systems thinking, it always captivated me, that the optimal performance of a system can often only be achieved by actively sub-optimizing the performance of individual components. The late Russ Ackoff, one of our lecturers in systems thinking, beautifully sort of demystified this notion for me with his analogies in architectural design and automotive engineering design. And I'm excited, actually, Robin is going to share some other thoughts on design with us later. So there's just a lovely array of design approaches for us to choose from in approaching a problem like an underperforming healthcare system. So in healthcare system terms, this would imply some kind of a correlation to me between an underperforming healthcare system and the behavior by actors within that system, whether it's the healthcare providers, public health administrators, patients, government, whoever, who have a tendency to defend usually and sort of maximally entrench their respective positions, right? And so what that does is I guess it leaves the dynamics of conflict and power to determine the ultimate state of the system. And then the other nuance that arises from this systems thinking view of healthcare is that a healthcare system, and especially a public healthcare system, is but one of several societal level systems, and it sort of lives enmeshed in and alongside other social systems. I think of the education system, I think of the financial, political system, etc. And at some level, all these systems act to reinforce the current state and whatever future trajectory there is for the overall societal system. Now, this term wicked problem was coined to describe those kinds of problems which stubbornly resist, a traditional approach to remediation and to being solved. And it's this enmeshment of the healthcare, as a system within a system that I think qualifies the problem of an underperforming public healthcare system as a wicked problem. So some of the attributes here within wicked problems is that remediation enacted within a system is typically countered by pushback from external or adjacent or related systems that are trying to return the overall system back to a sort of a stasis, or that the remediation activities, anything you do to try to solve a problem, creates issues in other related systems, and this in turn establishes feedback loops which ultimately undo any remediations you may have started with in the healthcare system. And if you look at the picture on the screen there, the subtlety there is that even after grappling for a while with a wicked problem, you may end up not even remembering what was the original problem that you were trying to solve in the first place. And I think that's where this idea of wickedness comes from. It's almost evil. And so from a futurist perspective, this means that, well, we clearly then need a different set of approaches, so different tools, different techniques to be brought to bear. If we ever hope to get to a resolution of this wicked problem. I'm changing tack here a little bit now, and I want to talk about how futurists view something significant like the current COVID pandemic. I know this is a lecture series. I think it's maybe not directly inspired by the thing we're all going through, but I think the pandemic also tells us some important stuff right now. So let's just spend a moment there. So pandemics live within a well-traveled set of let's call them macro events, which futurists typically game out. And you can see, so pandemic is one of them, but you can see some other examples of some other macro events on the slide there. So I really want to try and unseat this notion that futurists are going to give you a prediction of any kind of when and where the next pandemic is going to hit. And I hope the things I said at the start of my presentation make it clear why I take that position. But the pandemic, I think, also exposed a few other ideas or some other stuff to us, actually, because it became quite apparent in many spheres of society, not just in healthcare, and in fact in many societies around the world, that there was a rank lack of foresight-driven preparedness for something like a pandemic. Yes, there was emergency response, but I'm just keying in here on foresight-driven. And so while it's true that pandemics aren't happening every day and all of that, there's also, I think it's also true that we don't see that much evidence that there was a playbook for a pandemic response, and certainly that if there was a playbook, it wasn't being updated to take into account societal shifts, things like the impact of social media technologies or just shifting demographics or whatever. And so this is where these games, these war games or germ games, I think you've heard them referred to, have been instructive and sort of have a preparedness benefit. And gaming and gaming out and thinking through these pandemic scenarios can expose those vulnerabilities in a system in the case of a macro event, and will also open the system up to alternative moves, either moves to create capacity or be more proactively defensive, that improve resilience in the system and sort of counteract there's this idea that excessively complex systems are very fragile. Dave Snowden talks a lot about that. But sometimes we also see over-optimization of individual components, and that sort of reduces the resiliency. All right, I'm just looking at my time there. This is my last slide. I want to make a closing word just on practical implications. I wanted to include mention of some of the tools and the processes that could perhaps be employed if we were to redesign a public healthcare system. And here I'm drawing on some work that I did back in 2011 when I did the master's program in future studies. So the research report that you see on the slide there to the left was entitled Charting a Preferred Future for Healthcare in South Africa. This work described the design of a process only. We didn't go, through the ethical clearance and field execution stuff because, that was beyond the scope of the assignment, frankly. But the paper described the use of futurist tools like environmental scanning, causal layered analysis, systems thinking, scenario planning, all these techniques which live in the futurist toolkit. I don't have time to go into the specifics of each one of these techniques right now, but in summary, let me say the paper described a process of using those techniques to prime participants in a scenario planning workshop with a more futures conscious mindset, so that they could come into planning sessions with much more of a willingness to check sort of any actively and passively entrenched positions at the door, and collaborate in those planning sessions and envisioning sessions, even with opponents within their system. I was really trying to get them to imagine a future healthcare system that was so appealing that they would be motivated to return to their respective constituencies, and be so insistent, that the necessary shifts that each constituency would have to make to bring that future into reality was like non-negotiable. And I mean, I think that is an intriguing idea. And again, as a futurist, I'm going to argue that we know this is possible, especially in South Africa, because South Africa at large did exactly that in the late 80s, early 90s, when we essentially defied all expectations and, broke the track of the standard model. and pulled off a relatively peaceful transition from, an oppressive and conflict-ridden apartheid system to the democracy that we have now. All right, Renee, I'm at 13 minutes. I'll hand back to you. We'll elaborate some more during the plenary session. Thank you.
Thanks very much, Rafeeq, for that brief introduction and the overview of thinking around the futures. And Rafeeq and I had a discussion around his concerns with the terms future-proofing. So my sense was put it on the table. We need to interrogate all these terms and the way we perceive the future and think about the future. I also acknowledge that we have some health services people on the call. So things at the back of my mind certainly are what does this mean for the practitioner out there? And so I'm going to hand straight over to Prof. Heever, who's going to give his perspective on the futures of the health system and designing. Thank you. Over to you.
Hi, good afternoon. Just to clarify, my background is I'm an economist, and I've worked in health economics and financing, public finance, but also within the system, both in the public sector and the private sector, and that included setting up the regulatory regime for private health insurance in South Africa. So part of certainly my background and experience has been looking really at how overall systems respond to the various pressures they have to perform and in relation to their own goals. And there are huge problems that exist within the current South African systems design, and that includes its organizational components, its hospitals, its various authorities, its regulators, and its various departments. And many of them, I would argue, are kind of designed to fail. And I will go through why. And I think it fits very much into the previous kind of discussion. We have to look at organizations in a far more, in a different way to the way in which we have in the past, where you put up a building, have somebody in charge, have a hierarchy, and have some people who are meant to deliver some stuff. That has proven to be a kind of an approach and a system to healthcare. In fact, a lot of government departments and programs that means that they perform at a very, very low level in various different ways. So I'm going to go through the sort of my reasoning and how I would argue that we should think about this problem differently. And so I can't go through a detailed analysis of the healthcare system as it is, but I will try and touch on what I think are the important sort of thought points that are necessary to make the necessary changes. I just want to share my screen and show a few slides. I assume that you can see this. Is that the burning building? I think, is that obvious to people? Can that be seen? Slide. So.
Yes, it can.
Okay, so this is the fire that destroyed the head offices of the Gauteng Department of Health in Gauteng, and I regard this fire as highly indicative of a lot of the things that are happening within the public health system. In my view, this fire could not have happened if we had a different design to our health system. And it is one of the symptoms of a systematic failure that we will continue to see all across the public system, and will also be reflected in many ways as failures in the private system because of weaknesses in the design of the regulatory framework for medical schemes going forward. So I'm going to now run through how I would be thinking about this kind of problem. So the first issue is to say that all systems are really governed by their responses to internal and external pressures. So and how responses are also weighted depends on the extent to which these pressures threaten the survival or promote the flourishing of individuals that form part of the system. So if some people in a system feel that they are not threatened at all by something that is enormously harmful to society, that organization will not respond to it, even though it's harmful to other people. And that is part of clearly a design problem. How do you get organizations to weight their responses effectively? So most systems we can relate to are the organizations we form part of. So even though those organizations form part of much bigger and wider systems, but we relate to the objectives and the imperatives of the organization within which we operate. And so if there is something skew in that design, it's going to skew the performance of that organization. And if that organization is pivotal to an overall system, then the system will also become dysfunctional, depending on how important it is to the system. So in economics, now I'm going to refer to some economic terms, and I think equivalencies can be found in many other fields as well. But economics tends to refer to three forms of efficiency that any organization or system should attempt to optimize. One is your technical efficiencies, which is your optimal use of resources. Then your allocative efficiencies, which is basically how you're distributing your resources in taking into consideration the preferences of society. That will be your individual preferences or the social preferences, what people decide on as their social goods and services that they require. And then there's the third element, which is often completely ignored, which is dynamic efficiencies, which talks to innovation. So you can have a system which, through the way it responds and is weighted towards its internal and external pressures, actually responds principally to technical efficiencies, the optimal use of resources, but completely ignores dynamic efficiencies. In other words, it is designed not to innovate. It's designed not to, its responses and its pressures on it eliminate any incentives to change or adapt to and innovate. And so if you've misaligned the way in which your system is responding to various pressures, both internal and external, it's quite possible that you will have an organization that cannot dynamically adapt to changing circumstances in the timescale in which the change is required. So well-designed organizations internalize their responses to internal and external pressures such that they optimize all three of these forms of efficiency in realizing their organizational purpose. So the idea of an organizational purpose is quite important. That theoretically is what the organization is meant to achieve at the end of the day, what it's actually seeking to do. And however it's designed, it must have its incentives organized toward the achievement of those purposes or goals. So I'm going to move on to what I regard as something quite important at a very localized level in the performance of organizations and systems, but at the lowest level of any system, you'll have organizations. And your accountability regimes are very important that directly are essentially used to internalize these responses to internal and external pressures in relation to a set of objectives and goals. So what is an accountability regime and why do we have it? So in a market, you've got an accountability regime will be the consumer and the user of any kind of service for which they're paying. And if they don't like what you're doing, they go somewhere else. And there's a very immediate accountability effect on an organization that fails to respond to the preferences of society. So that can be of consumers. And that can be because you fail to adapt your product. So you've got the original Model T Ford painted in black, and you've got 90% of the market. And people want other colors, people want a different design. It doesn't really matter that you have 90% of the market because somebody's going to come in and offer color, somebody's going to come in and offer a car with a different performance level. You can decide not to introduce electric engines and somebody will ultimately enter the market with an electric powered car and you might have to adapt. So those would be instances where the responses to consumer demand will change the performance of organizations. So the question is, what kind of accountability regimes do we have in a public health system? I think this is a very important issue because much of the public sector does not have the relationship to consumers or users as part of generating an accountability effect, as would be the case of a market. A public hospital, for instance, can provide incredibly bad services to users and still continue to have its staff receive their salaries, and its very stupid and weak chief executive officer continue in their position and pick up a very generous pension at the end of the day. So the issue with a public organization is that effectively it has to have a specifically designed accountability regime in order to get those incentive effects internalized into the organization. And I would say that to a large extent throughout our public health system, our accountability regimes are dead to the users. And this is what would be referred to in institutional economics as a principal agent problem, in that the principal, which is the general public, doesn't actually have a direct way of holding an organization which is acting on their behalf, holding them to account, other than in a general election. Which is too blunt an instrument for the specific service in your area or any component of a major system. And this is really where we really have to think through our accountability structures throughout South Africa's public and private health systems. So I'm going to quickly, going to run out of time, but I'm going to quickly talk about the components of an accountability regime, which is in principle an overriding design, but it needs to be these are the sort of the key features of one, but which need to be specifically designed in relation to a public hospital, a district health system, any kind of health authority, a regulator, any organization that is effectively too distant from the users, that it requires some intermediary structure to hold it to account that's quite localized, not one that's too far away, but quite localized. So here's an accountability framework applicable to an agent. And an agent, let's say in this case, would be a public hospital. And then you've got the principal, who in many cases would be the general public or a specific user public in an area. An indirect relationship often requires some kind of supervisory structure that intermediates between the principal and the agent, the organization that's meant to be acting on behalf and that you want to perform in relation to you, in relation to all those three areas of efficiency that I mentioned. So theoretically, the indirect structure requires that you have a supervisory structure that is independent of the agent and that sets up and continuously modifies a set of performance requirements, which include performance measures and in wider systems, rules and laws. But for that to actually work, you require transparency. You require systems to reveal information on performance. So you've got your formal reporting structures, comes out of ICT systems, reporting measures, anything that actually shows you what the agent is doing. You've also got the media and the free press, and you've also got general public access to information. So the moment you remove transparency from the picture, it's almost impossible to hold anybody to account, which, by the way, is one of the reasons why in any authoritarian society or any organization or any monopoly or any structure which has a concentration of power, the first thing they target is transparency. They don't want you to know what they're doing, and they don't want to explain what they're doing or why they're doing it. And then the fourth component is consequences, something that we see doesn't really happen in South Africa's public system. Maybe if you bash somebody over the head with a glass bottle and you do it on TV, you might end up going to jail. But if you steal 100 billion rand from South Africa's taxpayers, you will not go to jail. There will be no consequences. But consequences are actually quite important in governing behavior at an organizational level. And these consequences are not just negative. They can be sanctions and they can be rewards. You make them too onerous and you'll have consequences, perverse consequences for organizational performance. If you design your performance requirements too stringently or too in ways that are too narrow, you can also harm performance. So you've really got to think through what your performance consequences are or requirements are, what you make transparent, and how you actually distribute consequences. Now, this framework also applies to the direct relationship where you've got consumers in markets. The logic is basically the same. In that case, the consumer becomes the direct supervisor of the organization through their using their money. So in designing a hospital governance framework, corporate governance framework, you have to go through each of these elements in order to get the correct balance of effects. If you get them wrong, that organization is going to spiral in a direction in which it will move in the direction of where the incentives are created. So for instance, if you've got a supervisory structure that is compromised, it actually is has a conflict of interest with the agent, there's going to be collusion, and they will exercise that collusion in their own private interest to the cost of the principal. That is what we're seeing throughout South Africa. You want to change that, you have to modify these relationships. In the case of consumers, the issue is that choice is your mechanism by which you're governing behavior. So it would be too long to go through all the slides I have. There would just be a few more, but I will finish off by talking to what I think are the problems with the way in which our reform direction is going in South Africa. And that everything that I'm talking about here is completely ignored in the policy reform process. People look at reforming the health system by creating additional public monopolies in which they consolidate power within the state structures so that they create very narrow gatekeepers to decision making. And they reduce accountability as far as possible. So what they typically do in the South African context is we have ministers who appoint people into hospitals effectively, MECs. We have ministers who want to appoint people into all the regulators in South Africa. So we create a conflict of interest between the supervisory structures and the agents. And that is the fundamental killer of all of our public organizations as well as our regulators. And as a consequence, it makes it incredibly difficult for us to actually create a coherent system which is made up of multiple organizations, regulators and hospitals and delivery agents of various forms, including private actors. So if your regulators are compromised, then conflicts of interest between the supervised and a supervisor and the supervised will result in those organizations acting in their own private interests to the detriment of the general public. So what you want to do in redesigning a system is to kind of look very carefully at how you fine-tune these mechanisms at every component, at every part of the system, to make sure that its incentives are correctly oriented toward constant innovation, that dynamic efficiency component, as well as other aspects of efficiency. So I will leave it there because I've run out of time, but I think that gives you the sort of the central premise within which I would use to kind of future-proof the health system of South Africa, which is to kind of redesign all of our key components that get our organizations and our systems in harmony toward particular strategic objectives. I'll leave it there.
Thank you so much, Alex, for that fantastic presentation. I think it certainly builds on the initial presentation where there was discussions around complexity and this wicked problem, that being the health sector in general, and then starting to think through what are some of the possible practical applications. We will open it up for discussion because it would be important to get a chance to have our audience respond and ask questions, but we'll move on quickly to Robin Dyers, who's going to discuss this using a slightly different lens, giving his perspective, and I look forward to the discussions after this presentation. Thank you, Robin. Over to you. And just to say, Robin, we can't hear you, so I'm not sure if you are still on mute.
Thanks, Renee. Just to say that I'm going to be changing course slightly to be focusing more on the design process. But first, as a brief introduction, I'm a public health specialist based at Western Cape Government Health Department and also doing PhD at Stellenbosch University, specifically in design science research and user experience design. And I'm going to touch on some of the concepts that Rafeeq has raised and also some of the content from Alex's presentation, but I'll be focusing specifically on the design process. We are all familiar or more comfortable with the concept of natural sciences. We know biology, botany, zoology, medicine as a natural science, earth sciences, chemistry, physics, astronomy. We're quite familiar with that. And design is sometimes seen as being very abstract and in the realm of the arts, but there is a scientific lens that one can use to the process of design. So according to Herbert Simon, when asked what is design, he says it is to design. To design is to devise courses of action aimed at changing existing situations into preferred ones. The intellectual activity that produces material artifacts is no different fundamentally from one that prescribes remedies for the sick patient or social welfare policy for the state. Design science research, on the other hand, is a research paradigm in which the designer answers questions relevant to human problems via the creation of innovative artifacts and thereby contributing to the body of knowledge. So we can consider the health system as an artifact. It comprises constructs of its components, which is ideas or terminology. For example, we've moved from the term of human resources, then we start talking about workforce, and now we're talking about people and people management. Another kind of artifact that we have is models of the health system. We've got representations from, we know models from Julio Frank, from WHO, Lucy Gilson, Keith Clutie. We know some of us are familiar with the Smarty Box from Joey, and going towards universal health coverage from the model that we're using from Corin Cheng. And then another kind of artifact is also the processes or the methods that exist between those components. Then we've got instantiations, which is the actual health system itself. And we can think of this at various levels, whether it is the health system in the Western Cape, the national health system, other regions, other countries, but these are it's the real world that we're talking about. And one can design for a model, or you can design for a process, you can design for the actual instantiation of changing the real world components. There is a fifth kind called design theories, but I'm not going to go into that today. So when we want to change or design a health system or adopt another model, we can take different approaches. We can be revolutionary versus evolutionary, or a hybrid thereof. We can take incrementalism versus non-incrementalism at the great risk of going beyond the capability of persons in that system. We do like the principle of it being participatory and strengths-based with appreciative inquiry versus problem-oriented. We could also use a hybrid of that. In the design science research process, we start off with a clearly defined problem, preferably a ratified problem that we all agree on, defining the objectives of a solution, and then comes the design and the development of that actual artifact, bearing in mind that that artifact can be a construct, model, process, or the actual system itself. Then we demonstrate that design, and importantly, we evaluate. And the way that we evaluate in design science research is that we appraise that the modified artifact against how well it solves the problem that we had initially identified. Okay, so yeah, I've got a few just vignettes of health systems that you may recognize. And so where do you begin? And it really does depend on how you've conceptualized the health system and its components, depends on the level of abstraction at which you've conceptualized it. And then it certainly depends on your power and your position within the system. How do you then adapt your model, or do you want to cast that model completely aside and start afresh, okay, with the risks that I had outlined earlier? So let's use the WHO health system model that we're quite familiar with. I dare not tamper with Alex's model that he had put up for us earlier. So I thought I would just go to this one that we've all started with. So models do not capture all the complexity of reality. They have strengths, they have weaknesses, they have assumptions. And in this one, this model, we can, on appraising it, we can see that it might be somewhat static. The relationship between the components on the left is not that clear. And the interconnectedness of the components is also not clear, something that Rafeeq alluded to, and in his first diagram, is that we know that all of this is, these are connected, and that there are systems within these systems. Within information, there resides leadership, finance, health, workforce, and service delivery, and within finance, etc. Okay, so let's then rearrange these components and then explore the interconnections between them. This is the interrelationship diagram, one of the tools that are used to deal with complexity, and models that in the health system that include representations of leadership usually come out tops in terms of when we try to appraise the leverage with that they would have within the system. If we ask ourselves, well, of these components, which ones affect the others the most? We find that leadership really affects all of the components, our leadership and governance. Coming in second is information, because of, and it's very closely linked to the leadership because of its ability to alter and to steer leadership in another direction. So not all proponents of health system strengthening seek to address the leaders and governance structures like head on. Sometimes we have to adopt smarter strategies of then going to other variables within our models or within these loops to influence leaders or to influence other areas within the health system. From here, we can rank these model components. People find themselves at different places within the health system, and they sort of got different perspectives. And so you've got to see where it is that you can have that knock-on effect to get the outcomes that one would like. So here we can see at the bottom, we've got the drivers that Rafeeq mentioned earlier, the links in this, and then the outcomes. And we often preoccupy ourselves with the outcome variables, trying to shape things, trying to move things that should actually be a product of what precedes in the at the higher ranking components. But so when one then appraises what I've just put up here, if we were to consider this as a modification to the model that I had put up, the original WHO model, we've got to ask, has this artifact become more useful? Has the artifact, is it relevant or applicable? Or as Alex asked, have we designed this to fail by virtue of gross assumptions in producing this ranking? Have we perhaps set fire to our artifact? So there are multiple perspectives when it then comes to designers to design. So certainly from a designer perspective, we create these products which have got their content, their intended character, and then they've got pragmatic attributes and hedonic attributes. And under those pragmatic attributes is what Alex alluded to, where we certainly seek effectiveness of our interventions, but then there's also, we want efficiency, technical, allocative, and dynamic efficiency coming from innovation. At the bottom of this of Hassan Zal's user experience model, there's also the user perspective, and there we can see the introduction of the situation or the context. So when designers make use of existing artifacts as a starting point, it's not because they're lazy or that they lack imagination, but rather because they are tapping into the body of knowledge that exists within that artifact. So much of the everyday design work that we do, or technical design, makes use of precedents or so-called best practices or previous exemplars. However, although designers may intend particular characteristics in their artifacts, they have little control over the consequences because they've got little control over the context in which this is going to play out. And that is why it is both users of the system that need to be part of the co-design and the co-creation to improve the usefulness and the applicability of the artifact. Just to bring this home, we strive to co-create a health system with artifacts between the provider and the user. But there is also then a third element, which is the environment, the natural world or the built environment where the consequences of the design is going to play out. And we should strive for synergy and for resonance and harmony between the artificial world and the natural world when we co-create as users and as providers. So on the left, for example, from natural science, and we often make use of the golden ratio, things that occur everywhere within our DNA, from the proportions on our body to the proportions on flowers and various things that we see in the beauty around us. We can also incorporate that into our infrastructure design. Certainly in our newer hospitals such as Khayelitsha, Mitchells Plain, Hermanus, CDC, District 6, we have improved the patient experience. We also, within our information systems, we create aesthetically pleasing and intuitive interfaces for the users thereof. And when we think of the natural phenomenon of birds' murmuration, there's no leader, there is no hierarchy that decides we're actually going this way or we're going that way. It is an absolute decentralized knowledge, whether we want to call it instinct or tacit knowledge, or whether it's inherent, but it's within each individual that makes the whole stronger. And in this age of misinformation and in our infodemic that we're finding that has surfaced now quite aggressively, we do need to look to models like this for how we safeguard our health information by using, for example, our decentralized immutable ledgers, like or simply put, blockchain. So when we think of health systems or health systems within systems, we can use the WHO model as a fractal. So leadership, if we think of the system within leadership and governance, leadership itself is an outcome variable within that governance space. So do we assume that there is some sort of murmuration between health managers? What are the levers within the microsystems of governance that we can influence to improve leadership performance and then ultimately improve health system performance? How do we improve then the accountability regime that Alex had alluded to? Thank you, and I will conclude there and hand back to Renee.
So thank you very much for that also very important and insightful presentation around aspects of designing and the research thereof and the science. And I think for me, the linkages also speak to Alex talking about starting to talk about aspects around effecting change and the need to redesign, and you touching on how we could possibly go about doing this. Can I, at this stage, before I pose some questions to the panel, ask if there are any questions from the audience or comments from the audience to the panel members? Thank you. You may raise your hand if you have anything to add. All right, so what I'd like to, okay, I think there are some hands. Yes, thanks very much. Gavin Regan, Prof. Chikta, Krish Vallabhji, I see your hands. If you can respond in that order, you can go ahead and unmute and unmute yourselves and mute yourselves again. Thank you very much, Gavin. Over to you.
Thanks, Renee, and thanks to the three speakers. So my question is to Alex. So you very eloquently presented the failures in the accountability, transparency, and consequences of poor performance. And in many cases that is quite true. So the question to you is, putting it in a positive way, what system design would you use to prevent that? Thanks.
Thanks very much. Alex, we'll take all the questions and then we'll allow you to respond. Thank you very much. Prof. Chikta, over to you.
Yeah, thank you, Rafeeq, Alex, and Robin, for a very stimulating, refreshing kind of look at these things. My question to Rafeeq, how do you transition from where we are here? I mean, you said the future is not some far away, it's like the next second. and how does one transition into this future as we go along? Alex, the issue around decentralization, how does that link up with inequity and the and almost absolving? And I agree with the decentralization and against a centralized system, but how does that address issues around inequity and especially in a situation like ours? And Robin, you said there is differences in visibility and architectural design, and that influenced it. What's the strength of the evidence of that? Thank you.
Thanks very much. I see Zamir's hands up as well. So Zamir, we'll take your question after we take Krish Vallabhji's question. Thank you.
Thanks, Renee. Thanks, colleagues. So my question is, these are complex issues, and really you can apply it at multiple levels, right from national right down to micro and local. And given our context of the last couple of months with the COVID experience, that has really pushed us in multiple ways to be much more agile and responsive in some ways. Given the context that we have an economic crisis in our hands in terms of austerity and what's coming down the line, those then become further catalysts now for having to do business differently. And the question is, and Alex, the national environment is a difficult environment, lots of politics and a range of other factors there. What is the scope for, within all of those constraints, for a province such as Western Cape to be able to, using some of the principles that I've spoken about this afternoon, to be able to take some steps in this positive direction of creating better accountability, redesigning our service, etc. So yeah, thanks.
Thanks very much, Zamir. Over to you.
Thanks, Renee, for setting up this wonderful session. Just so refreshing to all the speakers. Thank you very much. I guess, Renee, for me, I'm really interested in maybe a first question to Rafeeq around: have you done any scenario planning in terms of the COVID hit and what potential kind of macro changes, how they'll play out for the South African health system specifically? And then maybe a question to both to the panel here, and maybe some of the folks on the line is: should we not maybe seize this moment? It just feels like right now there's an appetite to do some of these words that were quite foreign, take on some of these concepts that were, potentially seen as outside the healthcare system. And shouldn't we maybe try and, sketch a couple of scenarios? Because I do feel like there are, while COVID has been a disruption, is there a possibility to transform that disruption into something super positive? Or are we just going to call it a crisis that we waddled through, we survived it, rather than we thrived on it? And what are those kind of elements in a post-COVID era that are worth planning around in terms of potential scenarios, so that we know what we need to hold on to in the post-COVID era? Thanks, buddy.
Thanks, Amir. Thanks to all the people who've posed questions. They're excellent questions. I'm going to hand over to you first, Alex.
So the first question is sort of how would we transition into the future? What would one do? Essentially what I've proposed is a way of designing a responsive system, understanding the design of a responsive system through making its components responsive. If they are not responsive to external, particularly external pressures, or if they're the way in which they are sensitized to respond to pressures is in any way misaligned, it will have an impact on how that organization performs in and of itself, and how the system performs and its role in a system. So a hospital that has a problematic accountability structure is likely to underperform in relation to its functions, to adapt poorly to the future, to adapt and incorporate and internalize new technology in inappropriate ways or not at all. It's likely to serve the interests of the people running the hospital rather than the people that it's meant to be serving, and it won't balance all the stakeholder responses effectively and efficiently. So how would I change things? I think that the issue is that I think that we need to rethink the governance, the corporate governance structures, the accountability structures around each of our components in the health system, every one of them. That's every regulator. The Office of Health Standards Compliance, which is meant to be a quality assurance regulator, has ministerial appointments from top to bottom. So that already kills the supervisory frameworks. There's no supervisory function, and that means that the accountability structure and its responsiveness to society is diminished considerably because it's filtered through the incentives of political office bearers. And that basically kills performance, and it will kill adaptability and responsiveness. So that needs to change. How you change it is each specific component of a system has its own performance requirement, and you need to design its accountability structure for its purpose. So there isn't a generic design. You have to look at all of those elements and refine them to make it responsive and adapt them if they fail to be so. So I'm really answering in a sort of very general sense. In my view, South Africa's entire health system needs a complete rethink. But that answering that question is also related to the question on sort of raising the issue of what would we do, let's say at a provincial level, given that national politics is so fraught. So the first thing that I would mention is that the politics itself, politics is meant to be a mechanism that connects society to government, to public structures. And if there's anything wrong in politics, it's suggesting there's something wrong with that connection. And that's an important thing to look at. There's something very, very wrong with our connection between society and the incentives that political structures have to actually create adaptive systems. So the moment you see that there is a political imperative to harm the performance of public organizations in fundamental and systemic ways, it's essentially a big signal that the political scenario, the way we've designed our organizations, our political accountability, is actually taking away the potential for creative change to our public structures. So that's just the first point, in answer just to that point that was noted. I would say that within the Western Cape context, the idea of decentralization and localization is very important. And I would say that that to be able to experiment with more local structures and more localized accountability structures in which one essentially hands a degree of veto power to communities and to certain stakeholders, provided it can't be captured, is a way of changing the incentives and the orientation of organizations. So it's worthwhile experimenting with that rather than with a classical hierarchical model. So even that without corruption is going to lack dynamic efficiencies. It's not going to be very creative in changing. It's just going to be reasonably effective. But I would say that the Western Cape is in a strong position to look at there's not enough experimentation with regulatory interventions that are not designed to be overbearing, but are designed to be enabling, on quality assurance, on performance, on clinical governance, those kinds of things, on information. And then the specific corporate governance designs around hospitals, district type authorities, and so on, that bring the users into the fray. I think just on the issue of decentralization, the decentralization and equity issue, these are two distinct issues. Equity is achieved through resource allocation. That's a distinct issue as to how the organizations that are funded through that resource allocation operate. Decentralization is about localizing accountability to the people who are users, bringing it closer to the ground, and then designing an accountability mechanism that can't be captured, that incentivizes appropriate performance. But equity is something that you do centrally. And I think that understanding the difference between what you do centrally and what you do on a decentralized basis is critical to understanding how big systems operate. The NHI proposals involve massive centralization. Therefore, they propose to basically move the entire system very, very far away from the users. That's the purchasing functions, just as one example. But decentralization says that you move the organization closer to the ground, your purchasing, so-called purchasing functions. But not everything's purchasing, not everything's about contracting. It's about how you manage, how you design organizations to perform. But equity objectives are achieved by the distribution of public resources that you can do centrally without harming the model of operationalizing your system. The NHI proposal suggests that you shift both operations, key operations, and resource allocation to the central level, killing all possibility of innovation in the health system and potentially destroying its performance. It won't get there, but even in concept, it's against the grain of how you'd redesign a complex institution. And I'll just make one further point just on some of the other points made in the talks. I think this issue of how you would transform big systems and complex systems requires an incremental approach. These systems are too complex to go in leaps and bounds. It's about prioritizing what comes next and keeping within the change in any system, keeping the change close to your capabilities. The more you introduce changes that are outside of your capabilities, the more likely you are to introduce more complications to the system that you didn't plan. Because most people can't cope with understanding. Most systems, most policy reformers can quite quickly move out of the realm of what they understand about what they're doing. So I think it's actually very important to start to adopt a different way of understanding the reform of complex systems as well, and not to go for big blue sky changes, but actually to go for manageable reforms that are going for the highly prioritized systems changes that will make the biggest difference in performance, and do them first. I'll stop there, sorry.
Thanks very, very much. Rafeeq, over to you.
Thanks, Renee. I'm going to try and take maybe Yusuf and Zamira's questions and then hand it back. I'll just try to be quick. So Yusuf was asking about how to transition to the future. I think Alex has commented on, made some comments here. A couple of thoughts. I think that, moving into the future is something like the sort of caution or the call out I'd want to make there is to say, we have to approach this, and our steps have to be about inclusiveness and drawing in more perspectives. The people who are running healthcare today are at some level explicitly and implicitly responsible for the failures of the system. We shouldn't condemn them to death, but I think that if we just expect that kind of thinking and mentality is going to reimagine something, especially against the backdrop of those incentives that Alex has described, we're not going to move into any kind of preferred future until we start working with additional ingredients. So I think starting a conversation, looking for collective and engagement type activities rather than just policy discussions in closed rooms kind of situation. That's my one call out. And I want to pick up on something Alex just said about taking how to bring about change in a complex system. I mean, Alex, I don't disagree. I'm also just maybe put something else on the table again for consideration, that when I look at the impact of, especially in commercial settings and in industry settings, of disruptive technologies or disruptive business models, we sometimes maybe have this perception that entrenched hierarchies and the established order of the day is very deeply seated and is like a giant thing that you can't topple it. And yet I think disruption in business has shown us that sometimes even very well-established players and mentalities can, in a relatively short period of time, change quite radically. And that often has to do with, and I'm connecting it to some stuff you said about the accountability structure. So I thought that maybe one of the other, I do respect the point that we shouldn't try and imagine a completely different expect to get a completely different public health system in 2 years or something. That's probably unfeasible. But I think this idea that the society that is the principal, the user of the health system, whatever level, also has an obligation to engage to improve its own, and not just to be a recipient and a passive recipient of this failing thing. And when you look at how consumer bases respond when the market is not offering them their products through innovation, through disruption, the society will and should be helped to create the systems that work better for it. So I think, Yusuf, between the comment about that we need sort of a collective mindset and we shouldn't be daunted by the massive and to Alex's point, the incentives are increasingly perverse to maintain this broken system maybe that we feel we sort of live with. None of those things necessarily mean it cannot be toppled. In fact, cannot be, I imagine a David and Goliath kind of an icon there. Okay. Zamir, you asked about whether we've done scenario planning on COVID. At the time, so probably back in April or somewhere around there were a number of webinars that had come out. The IFR, the Institute for Futures Research at Stellenbosch. I think Morne Mostert is the director of that institute. Actually did a webinar that looked at a set of scenarios around COVID. Those scenarios, again, I'm going to assume some level of familiarity, but you looked at sort of four quadrant, four possible alternatives, and for 4 different scenarios, and those were driven really by how virulent the virus was going to be and how responsive society and especially the sort of regulatory component of society was going to be in response to the pandemic. And maybe it's interesting because I believe now South Africa is moving, or things are going to level 1. It's interesting to compare, look back and what Morne was saying in those scenarios and sort of how things have sort of played out. But there was some work done in the context of scenario planning on COVID. And I also, Zamir, wanted to add one other thing that we did, again, just bring a bit more of a futurist lens to it as well. So there's this technique called causal layered analysis. I don't know how familiar people are with it. It's something out of the philosophical realm of post-structuralism, tries to find meaning in how society sort of responds at a surface level. So things like panic and so on associated with the pandemic can be drilled into and try to understand what collective beliefs drive that response by society. We did a causal layered analysis on the pandemic, and we're here in North America. I was working with a group of colleagues also in this Foresight space, and it was quite interesting what came out of that, which was some of the mentalities that are associated at a society level with something like COVID pandemic, and that those beliefs actually blind us to other resources that are available to us in order to improve our resilience and sort of have a better response to stuff like a pandemic. And so again, I feel like I'm rambling on it, but I just want to connect your questions, Amir, back to Yusuf's point about going into the future and how to design, because I think there's one other thing that we talk about, and I know Alex, who raised this in a previous conversation, is that the components in a healthcare system today come from a time and a world situation of British colonialism and all this stuff, and I don't yet. I hope we have the courage as designers, whoever is on this call, to also tap into, because there are other approaches to healthcare in the world, right, in the history of humanity, that have fallen sort of to the background, and I don't think they're all completely invalid. And so this idea that we can design a healthcare system that is organically synchronized, Robin, back to your point, a healthcare system that doesn't feel like an alien technology that has been visited on us, but something that feels like a naturally emerging, more effective, more reflective system to meet our needs. I'll stop there because I hope I've answered everybody's questions and points. Thanks, Renee.
Thanks very much. I'm mindful of time. Robin, over to you.
Sure, I won't be long. I will also just contribute to the question of how do we get to the future and to the notion of incrementalism. I think there is a tendency of where we apply incrementalism to all the components except the leadership and governance, where we tend to, when something is going wrong, someone must be axed. When a sports team is underperforming, fire the coach. And it's almost, this must fall is something where we want to be very heavy-handed with our leadership structures and with our governance. So certainly the question is, what does a quality improvement project look like for leadership and for governance structures? What is that incrementalism? How does one plan for that? Certainly in the Western Cape experience with our MEEP, or Management and Efficiency and Accountability project, where we saw incrementalism playing out of restructuring alignment to functions, but this over time, and then seeing how the system responds. And certainly COVID also fell right in the middle of that, and there was a sense in people of, oh, why is this taking so long? And as COVID forced us to just stop and reflect, I think there are going to be quite a lot of positive spin-offs from that, from actually just taking stock in that incremental cycle. And also the gradual introduction of our community action networks, which was something that I think made people a bit uncomfortable of letting go of the authoritative power and trusting members in our communities to follow through with their agency and with their leadership. That has certainly paid off when it came to food security, to housing, to the problems that people are facing now during the COVID pandemic. So yes, I would like us to really think a bit more about and with a more forgiving lens around that accountability and what that incrementalism looks like. Then just I want to first go to Zamir's question about transforming and using this opportunity to turn it into something positive. Well, of course, one would do this incrementally, but I think where Rafeeq had touched on loop and system behavior, the negative things that we're seeing, it's not just one negative thing. It is a vicious cycle that is going on. The immense corruption that we saw now, and the comments that we see on social media, kind of where people have given up, is because they have seen this vicious cycle before. So it's a question of how do we change that vicious cycles into virtuous cycles? How do we change the behavior of the variables within those cycles? And how do we then provoke the system in a positive direction? It is very difficult when we're dealing with these wicked problems that Rafeeq had outlined. From a design perspective, and I'd like to now touch on Prof. Chikta's question about the evidence around, I think I didn't quite get the question, but I think it had to do with the strength of evidence for applying the naturally occurring ratios to our environment that we build, and what is the strength of evidence on for outcomes. Just to take you back to that model that I put up from Hassan Sal, is that there are intended characteristics or desired outcomes. I think maybe that's a term we're more familiar with in health. So for those desired outcomes, it depends on your outcome of interest, whether we are looking at those pragmatic outcomes of what is the strength of evidence of designing a beautiful hospital for health outcomes. You're like, that's a bit of a jump. But if we look more towards our hedonic qualities and think of patient experience, and if we look at something like patient dignity and how patient and staff dignity of working in an environment that is not just aesthetically pleasing, but there's also got the synergy of the benefits of very strong RCT supported benefits of using those natural occurrences for even for IPC, for the way that we use our space, for our ergonomic, for our occupational health. There are various. So I mean, I'm afraid that the answer, a question of the strength of evidence is a bit unsatisfactory. From a design science research perspective, the question is, why is it performing that way? What is it within this artifact that is giving us these current results, and how do we then incrementally improve on that? Thank you. I'll hand over back to Renee.
Thanks very much to all the speakers. We've run out of time, but clearly the conversation is not new. And I'll just touch on something that Samir said, is should we not be seizing the moment? Is there not an appetite to start taking some of these discussions forward? And I certainly think there is. You know, just some of the reflections that I do want to add is, and I'm looking at the chat section, and I see that one or two of the comments has been made by people who I know work within the system. So there's a comment around decentralized models would require a major shift. There've been some other questions around, you know, that speak more to what level of commitment of government would there need to be. And I would like to ask our panelists to possibly look at those questions and try to answer it. The chat often continues after the webinar ends. And so that would be appreciated given our time, just you know, but to come back to my comment about the pragmatism of it all, is that I, for example, have been located by virtue of things I've done in the past and currently do sort of 1 foot in academia, and having had experience working in the services, and also with COVID-19, not at all being part of the activity, but certainly being an observer. And so one of my thoughts, or a few of my thoughts, are that at some level, some of the solutions are already underway, or there's a beginning of a discussion or an action around it. The second thing is that there are many things that are happening within the public sector in particular that, you know, and my question is, how does this link to what has been discussed? Where can we start building, and how do we start building, and how do we take an appreciative inquiry approach forward in and amongst everything else that we've spoken today? And so that brings me to another important point to mention as I close, is that the purpose of this discussion is to continue the discussion, is to continue to get the right people around the table, but also to invite our practitioners, our public sector managers, to speak and respond to this discussion and speak from their perspectives, and also to challenge others out there who need to be part of this discussion. And Alex partly answered the question when the question was asked. You know, my question was, who is responsible for changing things? And ultimately, his conversation led us back to some kind of intersection of politics and the political system. So at a pragmatic level, who are the players, who are the actors who are responsible for changing things? I will conclude by saying that as I transitioned from a more practical way of doing things into academia, my question was, what will be teaching the undergraduates and the postgraduates? And so where does the change start with who? And I think a very important part of this conversation needs to be rethinking curricula, rethinking how we teach. Who are we going to teach to start to implement change, and where do we start teaching? Right down at within primary, secondary education, tertiary education, and I think that's another important topic to pursue. I see there are some comments from Anthony Walkridge. We can't address them now. Certainly we'll look at it and reflect and think to take the conversation forward. There are many people asking for slides. We will make the entire webinar available on our website. Stacey Blaus will be sending emails. Please look at the flyer if you don't have the email address. And to conclude, just a thank you to the presenters. It's very important that we start having these discussions. Thank you for sharing your insights, and we look forward to ongoing conversations. Have a good evening, everybody. Thank you.
Thank you.
Thank you.
Thanks, Renee. Thanks, everyone. Bye.
Thank you very much. Bye-bye. Thank you.
Thanks.
Thank you and goodbye.